Let's discuss about preparation of the patient. Give injection of heparin 2 hours before operation. Give dose of antibiotics and continue till 5 days after operation. Pass Foley's catheter to empty the bladder. Cleanse vagina with antiseptic solution. Methylene blue is advantageous for staining vaginal skin at operation. Let's show you the video of hysterectomy. Phenon steel incision is given for many operations, but if suspected malignancy is there, or if diagnosis is in doubt, or if uterus size is more than 16 weeks of pregnancy, then midline vertical incision is given. Rectus sheath is cut, and then abdomen is open. Rectus abdominis muscles are not cut in this procedure, but these are split. These are separated. Then peritoneum is opened, and we approach uterus. Uterus is assessed, and then hysterectomy screw is applied at the fundus of the uterus. Before going to proceed further, packing is carefully done and small and large intestine is brought above pelvic brim. It is worth spending few minutes on this procedure because operation become easier and safer. Devers retractors are applied on either side of the uterus. Then ovaries are assessed. If oophorectomy is done, then infundibulopelvic ligament and round ligaments are taken separately. On left side, we are taking ovaries. We are doing oophorectomy because it was having multiple cysts. You can see left side of ovary is not good, having multiple cysts. Separate clamps have been applied on broad ligament and on infundibulopelvic ligament. With Vital 1 synthetic absorbable suture, we will ligate infundibulopelvic ligament. Mostly double ligation is done. On one side, ovaries are taken down, oophorectomy is done, while on right side, ovaries are preserved. In premenopausal patients, one of the ovaries must be preserved. Otherwise, patient will have to take hormonal replacement therapy. Because on right side adnexa are preserved, place one strong straight clamp like Cocker's clamp close to the uterus and across fallopian tube, round ligament, ovarian ligament and upper part of round ligament. When these structures are held on stretch, avascular window becomes visible at depths of 3 cm into broad ligament. Then second clamp is applied just lateral to first with tip at avascular plane. Divide the tissue and ligate lateral pedicle with number 1 absorbable synthetic suture like Vicryl, and mostly it is doubly tied. And if you are preserving adnexa, then you will have to repeat this procedure on other side. Second ligation is done on broad ligament. After this, open layer of broad ligament to reach utrovesical peritoneum. Clamps are being applied on broad ligament on either side. Then after this, layers of broad ligament are opened to reach uterosacral peritoneum. Then we will separate the bladder by pushing it off the cervix with swab wrapped around your thumb. Pressure should be on cervix, not on bladder. This dissection is continued till longitudinal fibers of vagina become visible, or you can also appreciate by gripping cervix between thumb and index finger. Before applying clamps to uterine vessels, first identify the ureter, either visually or by palpating medial leaf of broad ligament. Ureters are felt like whipcord, or it snaps as you move your thumb or index finger over the ureter. Now clamp uterine vessels by applying strong, straight or curved clamps like Mangold's clamp at right angle to uterus but at uterocervical junction. This should be doubly ligated with number 1 absorbable synthetic suture. Now open vagina by inserting scalpel transversely in the midline through vaginal fascia, then into vagina itself. Then extend incision to vaginal angles. Then apply Mangold's clamp to vaginal vault by placing one blade of clamp inside and other blade outside of the vaginal angle to include uterosacral ligament behind vagina. You can see Mangold's clamp is being applied at vaginal angle on left side. Finally, cut off uterus and cervix from vagina to complete hysterectomy. You can appreciate total abdominal hysterectomy is done with cervix intact with the uterus. You can appreciate both sides of vaginal vault. This vaginal vault is closed with series of continuous absorbable suture, number 1 synthetic absorbable suture. We can also close this vaginal vault using interrupted absorbable suture. Make sure there is no bleeding from vaginal vault or uterine vessels. This closure is done in single layer. If pelvic peritoneum is closed, then it is done with continuous 2-0 synthetic absorbable suture, starting it on one side and concluding at other end. This procedure is called peritonization, and this is mostly done when there is oozing from vaginal vault. But if there is good hemostasis, then nowadays many surgeons don't close this pelvic peritoneum. Care is taken not to include bladder wall into this vaginal vault closure. Mostly surgeons close vaginal vault in two layers, and second layer is actually peritonization. What are indications of hysterectomy? It is performed as part of large surgical procedure like removal of rectal cancer or large fibroid or other benign conditions causing severe menorrhagia, or it can even be performed along with ovarian cancer which was not diagnosed preoperatively. These are indications of hysterectomy. Unless gynecological malignancy is there, at least conserve one ovary in premenopausal patient. Now you can see pelvic peritoneum is also being closed over vaginal vault, taking pelvic peritoneum of bladder to the pelvic peritoneum from the rectum side. Second layer is complete now. Hemostasis is secured, sponges are counted, and then pelvic drain is placed. If there is concern of integrity of ureter or bladder, there are different options. Cystoscopy can be done. Indigo carmine intravenous injection can be given to rule out the function of the ureter, or if there is injury, urologist can be called upon. Close parietal peritoneum. Nowadays, most surgeons don't close parietal peritoneum or approximate rectus abdominis muscle together. Now close rectus sheath with polyglectin 910 or vitral absorbable synthetic suture in continuous manner. It provides strongest layer and cover to the wound. There are conditions when there are dense pelvic adhesions and ureters remain fixed deep in the pelvis, then subtotal hysterectomy is also done. Rectus sheath closure is complete now by applying Aberdeen knots at the end. Apply few stitches over subcutaneous tissue, then skin closure is done with Prolene 20 in subcuticular fashion. Knots are applied on either side of the wound. Knelton drain is placed. Stitches will be removed after 10 to 12 days. Injection lignocaine is infiltrated to prevent pain post-operatively.